Hi, my name is Paul Conway. I serve as Chair of Policy and Global Affairs for the American Association of Kidney Patients. And welcome to our second annual Global Summit on Kidney Disease Innovation. It's a great honor for me to introduce our next speaker, Dr. Vic Gura. Dr. Gura has a very distinguished career as a doctor, as an innovator, and as a friend and ally of patients and an advocate for the interests that we have in greater mobility and freedom through innovations in medical devices. Dr. Gura is the inventor and the innovator and the driver behind the wearable artificial kidney. And it's a great pleasure for me to have him speak to you about his technology, an update on it, and what it means for patients around the world. Without further ado, Dr. Gura.
I would like to thank AAKP and the University George W. Um, AAKP is a wonderful organization, and it's a very good channel for all the patients to have some say or some organized input on the issues that are affecting them and the rest of the nephrology community. So I think that the folks that take the time and their efforts to do that are doing a fantastic job. I also want to thank Dr. Raj Dominic from the University of Washington for his leadership in doing a great organization and a great nephrology division. Let's get started now with my disclosures. Here are my disclosures. A wearable artificial kidney, why do we need it? How does it work? Does it really do the job? And those are the main questions I will I'll try to answer. Why do we need it? When I'm in a room telling a patient that dialysis is necessary, it's a very difficult time for me, for the patient and the families or friends that are around, hopefully, in this difficult situation. And the questions that usually can come up are, what can I expect? How long do I have before I'm gone? Does it hurt? Can I work? Do I need help? Who's going to pay for this? And my answers, the answers of any practicing nephrology for these questions, are unfortunately not very good. So, what are the unmet needs in dialysis, and what are we trying to accomplish? We want to reduce the mortality, improve the quality of life, reduce the cost, improve access to the technology, and make life and cares more simple, because it's a quite complicated endeavor that inconvenience the life of the patients when they have to start doing this. So here is a list of all the many problems that affect the life of a patient when they are on dialysis with sitting on the chair doing time, the pill burden of swallowing a large amount of pills, fluid restriction. If they drink too much, we have to remove a lot. If we remove a lot, they cramp. If we don't remove enough, they choke with water in their lungs. They go a lot to the hospital. Most of the patients on dialysis are fatigued, are disabled, and cannot hold a job and be gainfully employed, and most of them have problems with even doing their activities of daily life. So these are things we want to solve in a wonderful document called the Roadmap for Improvements on Dialysis that has been developed in the community. These issues are clearly stated and are the uh, guidance of we need to solve these things. And I can tell you here now that the WAC solves uh, most, if not all, of these quite successful. And I hope I will make that point now. In the roadmap, we want to have a improved volume control, no sodium retention, less hypertension, no hyperkalemia, no metabolic acidosis, improved serum albumin, improve sleep patterns. We want to reduce or eliminate the need for pills and phosphate binders, improved appetite and nutrition, decreased need for blood pressure drugs, and decreased morbidity and mortality. Well, this was written by a kidney doctor. But if you ask the patients, the order in which these things are spelled out is a little different. Patients want more quality of life. They want, they care more about how they live whatever time they have than not necessarily how long they have. We have to respect that as kidney doctors, but the idea is that as a physician, I confess that's what I am. I believe that if we address these issues, each one of them, when it gets solved, then quality of life improves. And I'll discuss that a little bit further. So lately, people say, well, why don't we do this at home? And if we do it at home, people will be better off. And if we also would dialyze more frequently, longer, we can improve quality of life. But the way dialysis is structured today, uh, you simply cannot do more dialysis unless you're doing it at home. And if you live in Beverly Hills with 5 bedrooms and 2 people, you can definitely put more than one machine in your house. But if we are 5 people in 2 bedrooms, then it becomes a little bit more complicated. So those of us that sit around saying, "Oh, we have to do more dialysis at home," I would like to tell you that uh, it's simply not doable to the extent that the powers to be and the organizations want us to, because the technology doesn't allow it. You need more rooms, you need more space, you need water. Um, Many people want somebody to assist them because the technology is complicated, or because they don't feel very well with doing it, and they want somebody around. And we don't have enough nurses and technicians. And if we want to expand uh, the um, the amount of dialysis chairs available in dialysis units, there's no political or budgetary ability to simply double the amount of dialysis clinics that we have so people can come more open. Let alone the fact that patients don't even want to go to more often to a dialysis unit to begin with. They want their life back to do what they want to do instead of sitting around in a chair. So we said, well, how can we solve this? And I've shown this slide many times, and forgive me for being repetitive, but this makes the point. If we if we miniaturize things like the clock to the wristwatch, and the big computer to a more powerful device that is in the palm of your hand with a smartphone, we should convert a big machine that weighs a couple of 100 pounds, is operated with an electrical outlet, and requires 40 gallons of water per treatment, into something that people walk around with. So we did that, and we went from the large machine to a belt that you could walk around with and work on batteries. So this belt worked with blood in red that comes through a pump into the dialyzer, and then in blue it goes back into the patient. The dialysate in green goes into the dialyzer, comes out in yellow. It's regenerated and purified through those yellow circles that contain chemicals that cleans the dialysate, and it keeps going in a loop. This way, instead of using 40 gallons of water, we went to 300 cc's, and this was the diagram of the WAC in its second version, version 2.0. This is version 1 that was trialed in an animal in Cedars-Sinai. This is version 2, And the first human trial was done in Italy with Professor Ronco in blue. And in the middle, you have a patient that was strolling in the park. And This is a little park in the Vicenza Hospital where Professor Ronco works. And in the slide above, in the picture above in your right, you can see mother and daughter both on dialysis. Mother with a regular dialysis machine like we have today, and a daughter with the version 2.0 of the wearable artificial kidney. The second human trial was done in the United Kingdom, and we have patients that are wearing the device and walking around. Uh, with the tie-on, there is the late Hans-Dietrich Polacek, a most gifted engineer that mentored us and helped us a lot to bring the WAC to where it is today. And Professor Andrew Davenport, the gentleman with the butterfly tie, and he was another great mentor and collaboration that we are very successful to collaborate with. And then we did the first FDA trial in Seattle with the help of Jonathan Himmelfarb and a wonderful team in University of Washington. And here is the uh, human being, first human beings in the United States, and the first woman in the United States dancing with a wearable artificial kidney while getting dialysis, not sitting in a chair, not attached to anything. And this is the WAC 2.0. So this is the WAC 2.0, and when we use it, patients told us it's too heavy. It's 11 pounds. It's still not small enough. And although we were very happy with the lady in the blue box in the bottom, in the sense that we proved that the concept is doable, but there were still ways to go because patients were still not willing to walk around with this device and move around. So we learned in London that in 8 hours we removed all the toxin indicators that we needed to remove quite efficiently in 8 hours. And we removed enough urea and creatinine over 8 hours. So we said, well, if we can do this over 8 hours, why do we need more equipment to keep removing this over 24? So we went back to the drawing board and we said we're going to have a day version in which we remove the heavy components that you can see here on the bottom. And we went from 11 pounds to 2 pounds. To that end, we also had to improve the device. On your left is the old WAC pump from the version 2.0 that gave us a lot of technical problems. So we kept going to the version 3, and that in the middle is pump 3 of 18 pumps we kept building and improving until we came to what you see on the right hand side, where we have the latest version of the WAC pump, which is fundamentally different from what we had in the 2.0. And it gave us a lot of advantages in how the device performs. So going to the drawing board, we said, okay, how do we make this uh, smaller and more convenient for the patient? So this is one of the several sketches that we're starting to redo the WAC from the 2.0 to the 3.0. And we came up with a daily version that you wear around during the day. It weighs 2 pounds only, but it has a blood coming from the patient from the catheter into the dialyzer and going back, and the dialysate goes into one canister of sorbents, and then it goes back to the dialyzer in a circle. And this bag that contains the excess fluid that is removed is out of the bed. And we'll show you what happens when this is outside of the belt but still hooked up. So during the night, the belt hooks up to the three containers uh, of chemicals that do the job that needs to be done in 8 hours. So these three guys work over 8 hours to do what they need to do. Thanks to the new pump, our rate of removal of fluids is going to be much more effective. And then we started to play around with different models on how this is going to look, looking at different things that people put on their own bodies. We looked at belts that people put things in, and we even looked at dialysis patients that hopefully might have a wearable kidney on a backpack and go fishing. I do not believe that the 3.0 will allow you to do that. Maybe another iteration, but at least I want you to know that we were thinking of how we do uh, return to the patients in normal life, where you can go fishing if you want to. Uh, you can go. I'm not sure I can bring the WAC to scuba diving with the WAC on, but that doesn't mean uh, we cannot try. And we look at different models of things that people put in their bodies to carry things, from a holster to carry a gun, to uh, vests that can be worn in the field, and we even looked at different possibilities as where in the body you put what. And at all times, what we wanted is to give patients normalcy on how to do things. So we did a mock of the WAC in its version 3.0, and here we have one of our beloved designers. This is Lance, who did a fantastic job, and you'll see that. And we look, how can we give normalcy so you can move around, walk around with this, hopefully wear it under your shirt, so it's not obvious for people to see this. Many patients have expressed that they don't want to be seen with the device on their body walking around and people pointing fingers. We have to respect that. So with that in mind, we work a lot to see how we can make it not only light but discreet to allow normalcy. And we try to figure out where do we put what. So I told you that the waste bag with the pump that puts the waste into that bag are out of the belt. So they hook up here, but they can go in your pocket or in a table when you don't want to remove fluids. So this gives to the patients the ability to remove fluid if and when they want to. So it gives flexibility and choices to how to do this. And I'll explain that about the choices a little bit further. So this is one mock model that we produced with our designers of how the wearable will go. And you may notice that the parts are to the sides, so the person wearing this can bend forward without the impediment of these things in their belly. And we do need some suspenders so this doesn't fall. And you may notice that the catheter with blood, even though it's placed in the chest, like usually it's tunneled under the skin and goes and exits here. So you don't have a line of blood that can get entangled with things. And then you can open this and remove components as we would train the patients to do. And this is very easy. so it doesn't need a lot of manual dexterity or issues. And the fluid removal is done by a little pump with the bag, and you can roll the bag when it's empty and put this in your pocket. Now, if you have an elder patient in a nursing home, it doesn't really matter too much. But if you're working in your office, you can hook this thing up here and remove fluid. Then you want to go to Starbucks, you unhook this, the bag is now full, you go to the bathroom, empty the bag, you have your coffee, and this is not hooked up, so you have less weight on you, and you can go to the bank or to your Starbucks or to walk in the park, and then you come back to your office and you hook this back and keep removing fluid. So it gives patients choices on according to their lifestyle. If you have an elder patient in a nursing home, probably it doesn't matter too much. But if you're an active person that wants to have a significant life and do significant work, then this is a great advantage. This is an elder patient in this modeling that hooks up the night module during the night when he is asleep. But this lovely guy is here watching TV, removing fluid uh, when he's at home, and then when he decides that he needs to take his stroll in the park or go to the bank, he takes this off, and when he comes back home, he removes fluid again. And for the purpose of showing you this, we have to do it above the shirt, but we will strive to make it small enough so it goes under the t-shirt, under the dress, under the garment, so they don't have to be exposed to other people noticing this if they don't want to. People may choose to wear the device like this, and it allows a quite significant amount of activity for elder patients. You can, if you're younger enough and you hold the your whack under uh, your t-shirt as opposed to above the t-shirt. But if it would be under your t-shirt, you wouldn't see this. And you can go and take a hike, so to speak. And at night, you can put it with a night module inside a pillow or a teddy bear. And what are the advantages that we have for these patients? I mean, so, okay, it looks nice. Does it do the job? So this is a table that would take me a long time to discuss. But the advantages is that we remove enough fluid so patients can drink whatever they want whenever they want, and we can remove it. They can eat all the salt they want because this thing removes enough salt, so you can add salt to have a normal meal. We have shown in all the trials we've done so far that we remove enough phosphorus to make phosphate binders obsolete. So you don't need phosphate binders, and this has more than one profound effect. And if you don't have fluid overload and you don't have a salt overload, it stands to reason that they will not have swelling of the legs, shortness of breath, pulmonary edema, and go less to the hospital. Uh, you don't need needles that are painful, and most patients I know don't enjoy getting two thick needles stuck in their arms at all times. So those are some of the many advantages of this device. So patients can eat whatever they want. This lady was wearing the WAC in Seattle, but she could eat pizza, French fries, and drink cola to her heart's content. This is a trial of WAC 2.0, and you can eat a banana or cheesecake. This lovely guy is walking around eating whatever he wanted, and no need for phosphate binders. Let's talk about money. As stated by our good friend Eli Friedman, uh, the world cannot afford end-stage renal disease. It's unsustainable. And some of the economic advantages of the device we're bringing in front of you is savings of whatever the last time we looked at this is already close to 6.5 billion a year in just making phosphate binders obsolete. The charges for phosphate binders are about $900 per month. And if you do the math today, you go to 6.5 billion in savings just in making one drug alone obsolete. So we would have less hospitalizations, less hypertension, less cardiovascular disease, no phosphate binders, and a numerous amount of economic advantages with this device. So this lady would be wearing this under her shirt, and we went from where dialysis is today to the 2.0 to what we would like to see in the future. And this is what we are doing, not in the distant future. This is what we're building as we speak. Hopefully, the trial of the device, similar to what you see in this picture, will occur still this year. And this is not the brainchild of Victor Gura. There are numerous uh, excellent scientists, technicians, nurses, physicians that have been collaborating over a very long pathway uh, to bring this to where we are today. And this is my time to thank them and you for listening.
Thank you very much, Dr. Gurr, for your presentation and for instilling optimism in patients and researchers and innovators around the world. The wearable artificial kidney is exciting technology, and the American Association of Kidney Patients and George Washington University are excited to have had Dr. Gurr speak today. Thank you very much.